likelihood related to retention of CO2. This person was hit on head with a baseball bat and now he's unconscious, he's breathing slow and shallow with a low respiratory rate. Most likely his respiratory center is depressed, he is kind of unconscious and he is retaining CO2. Right. So his primary problem is ventilation and not oxygenation. So he does need a ventilator. Then why is he desaturating? He is desaturating because the accumulated CO2 is not letting the oxygen in. I'm trying to explain it in simple words. The accumulated CO2 is not letting the oxygen in. That is why he is desaturating. So this person needs ventilation. And what kind of ventilation? Positive pressure ventilation. So what exactly is positive pressure ventilation? How do we breathe? How do we breathe in normal day-to-day life? We breathe in. You must have seen your patients and you ask them, when you auscultate, you tell them, ek gehri saans lo, take a deep breath in. You ask them to, ek saans khincho. When we normally breathe, we take the air in, we suck the air in, it is a negative pressure ventilation. We create a vacuum inside our lungs and we suck the air in. That is called as negative pressure ventilation. The normal routine breathing is negative pressure ventilation. While when we actually ventilate a person, it is not negative pressure ventilation, we blow the air in to the patient. Right. So mechanical ventilation is positive pressure ventilation and it pushes the air in. Agreed? Let's go further. So for all practical purposes, mechanical ventilator is a sophisticated ambu bag, nothing more than that. I always say that a ventilator is nothing more than an ambu bag with a little mind of its own. It is like a 10th fail child. By the way, we decided that we are going to put this person on ventilator. What will be your first mode of ventilation? Write your answers while I come back in 30 seconds. Right. Well, they are ventilating with all kind of modes. Okay. Most of the people are writing volume control ventilation. We'll come to that. We'll come to that. So, like I said, ventilator is a 10th fail child with an ambu bag. Why I'm saying that? Long ago, a disclaimer, this is not a real story. Long ago, when I was working in a big hospital, like 20-25 years back, there were hardly any ventilators. Those they were not functional. Some of them were condemned and in a bad shape. We were in anesthesia. Some of the patients, when they could not be extubated out of surgery, they would be left in a ward or in an ICU without a ventilator. So what we would do, we had a ward boy. His name was Perpendicular, but we used to call him Ventilator. So we would give him an ambu bag and we will give him the patient that just keep ventilating this guy with ambu bag. And this ward boy will keep ventilating, just like the good old movie, Jab Tak Tere Haath Chalenge. So this ward boy will ventilate the patient till one way or another. This boy, whenever we gave him the patient, he would ask us only two questions. First one was, कि सांस कौन देगा? That is, who will trigger the breaths? And second question would be, कि कितनी हवा डालनी है? Just that. The ventilator, the ward boy would ask only two questions. सांस कौन देगा and कितनी हवा डालनी है. Right. So let's come to both these things. Whenever you put a patient on ventilator, like I said, ventilator is a 10th fail boy, he will ask you two questions. First is, सांस कौन देगा? What does it mean? There are two types of breaths. Whenever we ventilate a patient, there are two types of breaths. One is called as the mandatory breath and the other one is called as spontaneous breath or supported breath. Mandatory means the breath that is initiated by the ventilator, and supported or spontaneous is initiated by the patient. There are only two types of breaths. How does a ventilator initiate a breath? Ventilator has no mind of its own. You tell the ventilator that you have to ventilate this person at a rate of 15 breaths per minute. Ventilator calculates. Right. Ventilator calculates, okay, 15 breaths per minute, 60 seconds, 15 breaths. So one breath every 4 seconds. Fine. So ventilator will do 1, 2, 3, 4 breath. 1, 2, 3 breath. 1, 2, 3 breath. So ventilator triggered breaths are always time triggered breaths. The mandatory breaths are triggered by time. While when the patient triggers a breath, it is either flow triggered or pressure triggered. Now what does that mean? Whenever we breathe in a negative pressure ventilation mode. I told you that. So whenever the patient is on ventilator and if he tries to breathe, he creates a negative pressure, a suction, and that suction is sensed by the ventilator. It looks like this on a graph. This simple thing. This is the suction created by the patient. This is called as trigger or the patient trigger. All the ventilators are trained to catch this trigger and provide a breath according to the settings. In a pressure controlled mode, it will look like this. So, the breaths could be patient triggered or ventilatory triggered. Ventilator triggered breaths are mandatory breaths and time triggered breaths. Ventilator doesn't understand anything. You just have to tell it 15 breaths per minute, it will count 1, 2, 3 breath. If you tell him 10 breaths per minute, it will count 1, 2, 3, 4, 5, 6 second breath. Fine. So, so far we understood two things. One is that ventilator is a stupid child with an ambu bag. Then it will ask first question as who will give the breath, and you have to tell it whether the patient will trigger it or ventilator has to trigger it. Then the second question it will ask is कि हवा कितनी डालनी है, how much air do I need to give. Now there comes the concept of volume and pressure control. I'll explain this with an ambu bag. Right. So this is an ambu bag with a hypothetical lung attached to it. Whenever I ventilate a patient with this, the air goes inside the lungs and this balloon gets tightened. The walls of the balloon are experiencing some pressure. They are getting tight. Where is this pressure coming from? My ventilator. The more tidal volume I give, the tighter the balloon gets. So as much volume I give, the same amount it will increase. It will tighten more. More the tidal volume, more the pressure. Small tidal volume, small pressure. Larger tidal volume, larger pressure. Right? So when we come to concept of volume and pressure control, we can control only one thing. Either we can control the volume or we can control the pressure. Let me explain you more. Whenever I am pressing this ambu, this balloon is getting tightened. This much you know. Now, either I can decide that I will give 500 milliliters of air irrespective of what the pressure goes into the lungs, or I can decide that the pressure in the lungs will not go more than 30. Whatever tidal volume goes, I'll accept it. I'll repeat. I will push in 500 ml of tidal volume. Whatever pressure generates, it's patient's fate. Or I will not let the pressure rise above 30, whatever be the tidal volume. Agreed? In one case, I'm controlling the volume and pressure is in God's hands, or let's say scientifically, pressures depend upon the compliance and resistance of patient's lungs. In another case, we are controlling the pressures. We are not letting the pressures rise above 30, and whatever tidal volume is generated depends on God's hands, or let's call it compliance and resistance. Are you with me so far? If you are, then please write yes. So ventilator is a 10th fail boy. It can only do what is told. So please write in the chat box if you understood this concept of pressure control and volume control. In pressure control, we control the pressure which is generated in balloon. We cannot control the tidal volume. In another case, we can make sure that 500 ml of tidal volume is going inside. We are not sure of the pressure. If you understood this, just write in the chat box. A couple of no's I see. Okay, I'll explain it another way. Let's say I go to a shop and buy curd. Now curd is 115 rupees per kg. Now there can be two situations. Either there is a recipe which demands me to make exactly 1 kg of curd for the recipe, right? Either I need 1 kg fixed amount of curd. I'll go to the shop, I'll ask him how much will it cost me to take 1 kg of curd. He will say 115, I'll give him 115 and I'll come back. Next day the cost might be 125, I'll pay him 125. The other day cost could be 95 and I'll pay him 95. In other scenario, I am carrying a 100 rupees note and I'll buy whatever amount of curd the shopkeeper gives me. It could be 800 grams, it could be 1200 grams. Are you getting this? The same analogy applies in the ventilator. Either you can decide that I will not let the pressure go above 30, whatever the tidal volume be. Like in case of children, you cannot let the pressure go beyond 20, 25, 30. Or in case of volume control, you can decide that no, I have to give 500 ml of tidal volume irrespective of whatever the pressures are generated. Then it is volume control. So either you control volume or you control pressure. Abhi aaya? If aaya, then likho aaya. Likho aaya, double A-Y-A. So in volume control, we can decide how much tidal volume the patient will get. The peak pressure generated will depend on patient's lung compliance and airway resistance. Like this is your pressure time curve. Whenever you give some tidal volume, the pressure rises to a certain extent. This extent is called as P peak or PIP or peak inspiratory pressure. Right. Now, let's say the same patient develops pulmonary edema. His lungs are filled with water. You gave him like 2-3 liters of water. Now, his lungs are stuffed with water. Now, if you want to give him the same 500 tidal volume, it will give the same 500 tidal volume, but this time the peak pressure, instead of being 30, it will go to maybe 45. So you are giving the same tidal volume, you are controlling the volume, but this time the pressure needed to generate that tidal volume is way higher. This is volume control. The volume is guaranteed, but the pressure it will take to rise is not in my hands. And vice versa. If the same patient was on pressure control, I would keep the pressure target as 30. In the first scenario, it will give 500 tidal volume. In the second scenario, the pressure will not go above 30, but the tidal volume will be like 300, 350, 400, not more than that. Got it? Let's go forward. So in volume control, you control tidal volume and pressure is dependent on patient's lung compliance and airway resistance. In pressure control, We can decide how much peak pressures we can tolerate, but the tidal volume generated will depend on patient's lung compliance and airway resistance. If you have got so much, then write Aya in chat box and I'll move forward. Right. So our ward boy is ventilating the patient. We have told him that सांस कौन देगा? You have to give him सांस. Patient is unconscious, patient is not breathing, patient is almost comatose. You have to give him all the breaths. Fine, he understood. Then you told him, उसने पूछा हवा कितनी डालनी है? You told him 500 ml 15 times a minute. Fine, he understood. Now he has taken his ambu bag and he is giving 15 times 500 ml. So now he asked us, what are the 4 modes I can give? What are the modes I can give? So there are 4 ways you can deliver this air. These are CMV, ACMV, PSV, SIMV plus PSV. Let's go there one by one. So in the first instance, our ward boy is delivering oxygen to the patient. He has this ambu bag and he has the patient. Now, as we have told him, and he follows whatever he is told to, he is giving 15 times 500 ml. Okay. 1, 2, 3, 500. 1, 2, 3, 500. 1, 2, 3, 500. And things are going wonderfully well. Everybody is happy. But then, Baba was unconscious because of his rising CO2. Now, as the CO2 is getting washed, the Baba is becoming more conscious. His respiratory drive is coming back. Baba is trying to breathe. Now what happens? That Baba is trying to breathe out and the ventilator is in its 4th second. So 1, 2, 3, Baba tries to breathe out and ventilator gives. Again, Baba is pareshan. Now, again 1, 2, Baba tries to breathe in, but ventilator says no, no breath till 4th second. Okay, fine. Then 3rd time, 1, 2, 3, Baba tries to breathe out, ventilator gives breath in. There is patient-ventilator dysynchrony. Patient is really, really uncomfortable. This mode is called as controlled mandatory ventilation, CMV mode. What is CMV? That everything is controlled by ventilator. There is no respect of patient's wishes. If he wants to breathe in, breathe out, I don't care. I'll give whatever I have been told because I'm a 10th pass student. Fine. Now what do you do? So this mode failed. Why? Because all breaths were delivered by the ventilator. Tidal volume is fixed. You are told 500 ml. Minute volume is fixed, 500 into 15. How much? Whatever. Then rate is fixed. You have told him 15 times. Everything is fixed. There is no respect for patient's triggers. P peak depends upon compliance and resistance, of course. And there is no respect for patient's efforts. And it is very uncomfortable if the patient is awake. And believe me, most of the times, in most of the ICUs, we see all the time patients on CMV ward and fighting. But that's the harsh reality. If we could change one thing with this lecture, I'd be more than happy. So only one place where it should be used is the operation theatre, because we sedate and paralyze our patient and we control every breath of him. In ICU, CMV should be given maybe to a person who is completely comatose and probably not going to wake up anytime soon. Otherwise, CMV shouldn't have a place. Nowadays, they don't even have a separate CMV. They have it CMV/ACMV mode. So what is ACMV? You understood CMV mode, right? ACMV is more like zyada pyar karne wali maa. You must have seen, especially in in modern helicopter parenting, you must have seen the parents who are like too caring for the child. कि बेटा भूख लगी ले और खा ले, बेटा फिर से भूख लगी ले और खा ले, बेटा फिर से भूख लगी ले और खा ले, and the beta keeps eating and eating and eating, and then they go for obesity problems. ACMV mode is exactly like that. Now what happens in ACMV mode? Our 10th pass boy, he went back. The HOD, Dr. R.D. Singh, he told him, ki, no beta, this is not working, the patient is fighting, the patient is struggling, and because of that struggle, because of that dyssynchrony, the patient is going into hemodynamic instability. Of course, if patient is trying to breathe in and you are giving breaths, the patient will go into hemodynamic instability, there will be tamponades being created. So the child asked, the ward boy asked, what should I do? Okay, the HOD told him, you have to give him 500 breaths 15 times. But whenever the patient tries to breathe, you have to honor that trigger also with a full tidal volume breath. Okay, the ward boy was more than happy. Okay, I know what to do. Fine. Again, the ventilation started. 1, 2, 3, breath. 1, 2, 3, breath. 1, 2, patient triggered 500 ml. 1, 2, patient again triggered 500 ml. 1, 2, 3, 500 ml. Eventually what happened was 500 ml, 15 breaths were given, mandatory. And patient also tried to breathe 10 times. So eventually 25 breaths of 500 ml were given. What will happen? The patient will hyperventilate. The patient will wash off his CO2. The patient will go into respiratory alkalosis. So ACMV is good. But the problem is the patient hyperventilates with ACMV. Why? Because every patient triggered breath is supported with full tidal volume. In CMV, patient triggered breaths were completely disregarded. No, you are not breathing. In ACMV, we are loving him too much. So whenever patient tries to breathe a little, we give him more tidal volume. So every time the patient breathes, we give him 500 and mandatory 15, so we are giving already. So ACMV was good, it is still being used, but there is a problem that if the patient is on spontaneous and he's like tachypneic, he will eventually get like 15, 20, 25 liters of minute ventilation in a minute. Right. So let's go further. This mode was also having its own set of problems. So in assist control mode, mandatory breaths were delivered by ventilator and patient could initiate a breath, but then the ventilator will take over and deliver the full predefined tidal volume. Each mandatory breath and each patient triggered breath is given same tidal volume. Eventually, the patient will hyperventilate, and these are not true spontaneous breaths because the patient is just triggering. Other than that, the ventilator takes over, and the problem comes of hyperventilation. So again, the HOD, Dr. R.D. Singh was not happy. He told him, Dick, Baba is awake now, he is trying to breathe by himself. Why don't you let him breathe by his own? Whenever he breathes, you just support. Don't give him any breaths, just support him. The ward boy was fine, okay, whatever you say. Now, the next mode that was decided was pressure support mode. And in pressure support mode, it was left to the patient. The patient has to breathe on his own. His breaths are literally in his own hands. He has to trigger his own breath and the ventilator will just support. In pressure support mode, how does it work? The ward boy is with the ANBU bag. Patient is not breathing. Now the patient triggers. The ventilator supports with a positive pressure of, let's say, 15 or 12 or whatever number you set. Right? So everything is silent. The patient tries to breathe. The ventilator supports with 15. 2-3 seconds silence. Patient again triggers. Ventilator gives 15 centimeters of water pressure support, not a fixed tidal volume. It is just giving a support. What will happen? Everything will be fine. It's the one of the best modes. What will happen? That all breaths have to be triggered by the patient only. Then the ventilator will add a fixed predefined pressure to the patient's effort. In CMV and ACMV, the tidal volumes were fixed. In PSV, the tidal volume and respiratory rate both keep changing. The respiratory rate will be decided by the patient's efforts, and the tidal volume will depend upon the combined effort of patient and added 15 centimeter water of ventilator. Getting me? In PSV, the respiratory rate and tidal volume, they keep changing. Maybe if the patient is tachypnic, the rate will increase, and tidal volume will depend on two things. A, how much effort patient is generating, plus the 15 centimeter of ventilator given breath. So you cannot decide what will be the minute volume or anything. But this is a very good mode if your patient is awake, if your patient is in weaning, right? If your patient is awake, if your patient is in a weaning mode, pressure support mode is one of the best modes. In fact, I would say if your patient is struggling with the ventilator, just put him on PSV and watch. Just watch what exactly does he want. If he is getting tachypnic, then maybe he needs probably more tidal volume. Again, we'll go to weaning some other day. Right now, it is just about differentiating the modes. So in PSV, all breaths are initiated by patient. Ventilator adds 15 centimeter of water or whatever you add. The rate and tidal volume keep changing. It is a weaning mode, and it is also used in combination with SIMV mode. So our boy puts the patient on PSV, and everything is going fine. Whenever patient asks, our boy gives 15 centimeter of water, and everything is wonderful, except for one time. The boy is ventilating the patient, and what happens with all these awake patients is they just keep asking for water and everything. The patient is awake, he has a tube, and then he'll ask. And what will happen is, at night, especially if the patient is too much troubling, some of the senior nursing staff will eventually sedate the patient. So what happened was that our boy was ventilating the patient. Then somebody came and gave like 2-3 ml of midazolam to the patient. The patient stopped breathing. Boy kept waiting. Well, I have been told when the patient triggers, you have to ventilate. The patient never triggered, I never ventilated. In the morning, the Baba was there, obviously. So the HOD, Ramadhir Singh ji, he just bid goodbye to the ward boy. Then a new mode was discovered. So CMV was good, but it has its lot of problems. ACMV was better, but with slight problems of hyperventilation. PSV was wonderful, but the patient needs to be conscious and awake. Nowadays, all these modern ventilators have a backup mode. If the patient doesn't breathe well on ventilator, they go to the apnea mode or backup mode. So whenever you put a patient on PSV, you have to set the backup settings also. Then came the mode called as SIMV. In SIMV, the patient will also breathe and the ventilator will also give its breaths. That was called as synchronized intermittent mandatory ventilation. Now, what does it mean? Let's say we have set a rate of, we have set a rate of 10 breaths per minute. That means in 60 seconds, 10 breaths have to be delivered. Every 6th second, 1 breath will be delivered. Now, what happens with SIMV is that the ventilator will wait 1, 2, 3, 4, 5. If by 6th second patient does not trigger, it will give a mandatory breath of 500 ml tidal volume, whatever you have set. It will again wait 1, 2, 3, 4, 5. If by 6th second no breath is triggered, it will give mandatory breath. So it will ensure a rate of 10 and a tidal volume of 500, which makes it a 5 liter of minimum minute ventilation to be given to the patient. But if the patient triggers in between, the ventilator will keep quiet. So the ventilator will keep giving the triggered breaths, the mandatory breaths, and by any chance, if the patient triggers at the time of the expected mandatory breath, then the ventilator will turn that triggered breath into mandatory. Didn't get it? I'll explain. 1, 2, 3, 4, 5, 5.5, patient triggered. So ventilator will convert that triggered breath into a 500 ml tidal volume breath. Getting it? Now, same way, this SIMV, again, 1, 2, 3, in between the patient tried to breathe, ventilator ignored it, 4, 5, 5.5, and the ventilator gave the mandatory breath as a supported breath. So this was synchronized intermittent mandatory ventilation. It had one problem, that the breaths that were coming between the mandatory breaths were not respected, and the patient felt dyspneic. Right? Let me check the comments again. Just a moment. Right. So mandatory breaths were just like CMV. Patient can take spontaneous breaths between mandatory breaths, but the spontaneous breaths could be pressure supported, but in plain SIMV they were not pressure supported. It was again a common mode of weaning. So what is the difference between ACMV and SIMV? In both ACMV and SIMV, patient can initiate a breath. In ACMV, each initiated breath will be given full predefined tidal volume. In SIMV plain, each initiated breath will have its own tidal volume depending on patient's effort. Ventilator will not support it. Then this plain SIMV mode was also disregarded. Nowadays they don't use plain SIMV, they use SIMV plus pressure support. And this SIMV plus pressure support is practically best of both worlds for the patient, because it gives a mandatory ventilation whenever the patient is not breathing. It supports the patient triggered breaths, and it respects the patient's wishes to breathe. So how does that work? Let's see. In SIMV plus PSV, what happens is, let's say we have set a rate of 10 minimum and a tidal volume of 500. So how will it start? 1, 2, 3, 4, 5, no breath triggered, 500 ml of mandatory breath. That is SIMV. 1, 2, 3, patient triggered a breath. Ventilator will support it with 15 centimeters of water. Maybe the tidal volume will go to 200, 300, 400 depending on patient's effort. So 1, 2, 3, patient triggered, the ventilator will support it with pressure. It will not give a full tidal volume like ACMV. It will support it with 15 centimeter of water pressure, just like the PSV mode. So in between the mandatory breaths, it will act like PSV mode, and at the time of mandatory breaths, it will act like CMV mode. And what happens if the patient tries to breathe at the 6th second exactly? That time the ventilator will give the full tidal volume breath as if it was a mandatory breath. So again, 1, 2, 3, 4, 5, nothing triggered, mandatory breath. 1, 2, 3, 4, 5, 5.5, patient triggered. It will give 500 ml of tidal volume to the patient triggered breath, right? And 1, 2, patient triggered, it will give 15 centimeters of pressure support. You are getting it? Whenever the patient is trying to breathe in between the two mandatory breaths, it is giving pressure support, And at the time of mandatory breaths, it is giving full tidal volume breaths. And by any chance, if the patient triggers exactly at the time of mandatory breath, it will synchronize the breaths. That is why it is called as synchronized intermittent mandatory ventilation. It is best of both systems. The patient is allowed to breathe on its own. The spontaneous breaths are supported with pressure support. But if he fails to breathe, the ventilator gives minimum fixed minute volume mandatory breaths. Then it is commonly used in weaning or conscious patients. Let me show you two diagrams to explain it even better. This is the plain SIMV mode. Now this is a mandatory breath. It is not triggered by anything. It is time triggered mandatory breath. Then in between the two breaths, these are the patient triggered breaths which were not supported. They did not generate any tidal volume. But the patient will feel dyspnea. The patient will feel that he is not able to breathe. Now at the time of mandatory breath, if the patient triggers, then that mandatory breath is converted into a supported breath of 500 ml tidal volume, right? So this is a supported breath, triggered breath, which came exactly at the time of mandatory breath. And these are the breaths which were ignored. This was plain SIMV, which is not used anymore. Nowadays, we use SIMV plus pressure support. So how does it work? This was a patient triggered breath and it was supported with pressure support, and there is a minimalistic tidal volume. This was again a patient triggered breath, but it fell at exactly at the time of mandatory breaths, so it was given full tidal volume. This is again a patient triggered breath, so it was given a pressure support. That is how it works. So this is SIMV plus PS. These two are patient triggered and pressure supported breaths. This one is a mandatory breath. Right. So that brings me to the end of this lecture. There are so many other modes like PRV, CAPRV, bilevel, oscillatory, volume support, BiPAP, CPAP, reverse ratio. So I don't want to juggle up all these modes together. This will be the end of part 1 of this lecture. I will do another part of this lecture, maybe in accordance with the Netflix people, or I'll do a simultaneous cast of this lecture, the second lecture, advanced modes, on my own website. You can just write down the address and you can just type it, just put in your number there and I'll inform you. Or maybe you can search for my platform, you'll get a link of that free class. So that is all for now. I guess now I'll take the questions. You can just drop your number there, so whenever the second class will happen, I'll inform you. I guess right now we'll finish with the part 1. The second part we'll learn about the other modes. If you liked this lecture, then maybe you can write happy in the chat box. नहीं इसमें नहीं आएगा, चैट बॉक्स इसमें आएगा. Nivedita, over to you.
Yes, sir. Thank you, sir, for that wonderful lecture. If y'all have any questions, just put it up into the comments section and we'll pick it up here. We're getting a couple of